Dr. Poelstra is a world-renowned spine surgeon who has performed the most number of robotic spine surgeries in the world and has a heavy focus on minimally invasive surgery all the way around, MIS deformity, and industry-leading outcomes data on patient recovery and length of stay. And Dr. Poelstra would like to share some thoughts on this alloy.
As many of my fellow surgeons and engineers understand, is that we are sort of held captive by what is approved through the FDA to be able to design the next best generation of implants, right? Molybdenum rhenium. Most people that hear it for the first time, they can't pronounce it for another week, although they try really hard. But if you look at the little pie charts there, you can see that it's truly just basically half molybdenum and half rhenium, and it's been tried as a super alloy for very high-end aeronautic applications and so on because of its superior strength and the fact that there is no trace elements of anything else, which for a variety of reasons is not great. But unfortunately, for what we have to use in our patients, it's a necessity to keep the materials stable and to give them the properties that for the past 50 years we had to use. So if you look at the middle pie chart there, cobalt and chromium, it has indeed cobalt and chromium primarily in there, but you see all these other trace metals that are in there to keep the alloy stable and to give it the properties that we were able to use in patients. But unfortunately, having nickel and iron in there gives you potential problems with patients with allergies, and you have issues with imaging because of the artifact that gets created. And the same is true also for titanium. We know it as titanium, aluminum, vanadium, right? There's some other things in there too. And there's some iron trace elements also that you should not underestimate when it comes to imaging. So since March last year, molybdenum rhenium was approved in a pedicle screw system called Europa, and you don't get through the FDA a metal, right? You get an implant, and then the implant was married to a molybdenum rhenium rod. The work that has gone into it and the engineering work, I have tremendous respect for all the engineers. They have worked tremendously hard to get this out there, and it's almost a moral obligation, I think, for the next generation, which we are after cobalt chromium got approved, to get something better out there. So with that sort of as an introduction, how special this is, we can look at what this material actually does. As a metal itself, cobalt chromium is stronger there, right, than the titanium we're used to have for our most of our implants, and was used for deformity applications. Now that's being surpassed by molybdenum rhenium. So this is a material property that suddenly allows us to have a 2 or 3 times as strong metal to build things for the benefit of patient care. So this is a tremendous leap forward, and this is allowing then what you will see, having rods that are much thinner and so on. So if you compare this metal in like the bench testing, right, that is required, you see the gray bar with the 5.5 millimeter titanium rod. What the requirement is to make this rod bend and flex 2.5 million times in a standard study of a corpectomy model. So you have to imagine there's a corpectomy defect, there's 2 rods, and you basically put it in an Instron machine and move it. You have to move it 2.5 million cycles for this FDA test. And in titanium, you can do it with 150 newtons. The rod fails after this 2.5 million cycles. You can go up to 200 newtons with cobalt chromium, since the material properties are slightly more favorable, but this is still with a 5.5 rod for both systems. Now, if you look at the red bar, it is a 4 millimeter rod, and you can bring that rod to 2.5 million cycles with 350 newtons. So it is twice the load, and the volume of material is half. If you think about 5.5 to 4.0, not much of a difference. Well, it really is, because the true volume of that material is half of what the titanium 5.5 would be if you compare it to a 4 millimeter molybdenum rhenium rod, and it still surpasses it by about double when you look at that graph on the left-hand side. And then the other thing is that it's very important for us, right? If we bend something and we go like, well, this was a little too much, or I need a little bit more, the bending and unbending is very harmful for metal rods, right? It leads to earlier rod failure, and it's made out of titanium. You lose about 17% of the durability of that plate. Similar in the spine. If you do it to cobalt chromium, it's a little bit better because the properties are a little bit more advantageous. But look at molybdenum-rhenium, the 4.0 rod compared to 5.5 of its nearest neighbors only lost 9% of its durability. So you can bend it back and forth, and I think that's going to open up a tremendous opportunity for, say, deformity systems and making things smaller. This is a classic example, like morbid obese female had, prior surgeries, decompressions, eventually a fusion at 4.5 that unfortunately for her ended up in a pseudoarthrosis. I mean, we see all of these cases all the time, right? She has a little bit of a spondylolisthesis at 5.1. She had an SI joint fusion because they thought that was where her pain came from. That failed too, and then eventually she ended up with stenosis also at 3.4. And then you have that post-tail hardware, right? And there was always an issue, and still for a lot of surgeons now, you have to get the hardware removal set, and sometimes the screwdriver doesn't work, or to think really hard, can I leave that old stuff there? Because the longitudinal rod, it's a 4.0 or a 4.5 molybdenum-rhenium rod with superior strength. I can get that maybe next to existing hardware. So anterior column support, details of how it was done doesn't necessarily matter, but on the next picture, when you see I take her for the posterior hardware, I think just, great anterior support. So all I have to do posteriorly is recreate the tension band to allow this load sharing of my anterior column. And that's where this material is unbelievably superior, because look how I completely ignored the existing hardware. I didn't have to take it out. I just made 3 poke holes on both sides of the spine to put in my hardware just to allow the anterior column to do its work and fuse. So it has been a tremendous advantage to using smaller hardware, and I would say, see for yourself and hold your current construct and then hold this in your hand and do a couple of cases, especially percutaneously, and you'll see how easy it is and how little soft tissue trauma is actually necessary to get the hardware in there.